Welcome to the MedEvidence podcast. This episode is a rebroadcast from a live MedEvidence presentation.
My name is Manish Jain. I'm a rheumatologist. I'm actually right down the road. I'm at Ravenswood Rheumatology, just a little bit west of here. It's a pleasure and a joy. I've been seeing patients for now, about 13 years, lucky number 13 as a practicing rheumatologist. But I've been working within clinical trials for about 10 of those 13 years. And that's been a real joy for me as well, to bring cutting edge treatments to my patients who are in practice. And I've been doing that with a research center that's kind of attached to my practice, again, right down the road on Wilson and Damon. We're here today for a few different things, right? So we really want to talk about diabetes. We want to talk about chronic kidney disease. And so I'm a smart guy, but I've brought in someone a little smarter than me to kind of discuss both of those topics, both diabetes and chronic kidney disease. And then we're going to, at the end, kind of tie it back to some of the great work that we're doing right down the road with clinical trials. So with all that, I wanted to introduce my colleague, Dr. Khaleel Sayeed. Dr. Sayeed, why don't you tell us a little bit about yourself?
So as Dr. Jain said, I'm Khaleel Sayeed. I have been practicing now for almost 10 years. My practice is a little bit south of here, out of St. Mary's Hospital, but I do have colleagues who also practice on the north side, close to Dr. Jain at Swedish Covenant Hospital, which is a little bit west of here. As Dr. Jain said, I am a specialist in kidney disease, and as some of you may know, diabetes is the #1 cause of kidney disease in the world. And so I am excited to talk to you all about both of those things, as well as some of the new therapies that are available to help treat and slow progression of kidney disease and treat diabetes, and how some of those therapies came about, and how Dr. Jain and I are now involved in helping develop some of these newer therapies that will hopefully be available in the future to help combat and slow progression, and then also prevent the development of kidney disease, hopefully.
Yeah, perfect. So, and just quick show of hands, who in this room has had the life of a loved one, a family member, a friend, maybe even yourself touched by diabetes? Quick show of hands, right? I'm raising my hand, right? I got multiple family members with diabetes. Quick show of hands. Same question, right? But for chronic kidney disease, who has a loved one or family member, someone who's been touched, right? So again, we kind of get a sense, right? These are very, very, very important diseases to think about and talk about. So we're going to kick it off with a quick question. Which of these is not a real type of sugar? Sucrose, fructose, glucose, confusose. What do you guys think here? Sir, what's the right answer? Confusose, exactly. Yes. So we'll be talking about sugar here as we go along. So, true or false? Some animal studies suggest that sugar can activate brain reward pathways similarly addictive to brain reward pathways seen in cocaine use. True or false? Sir? True. Very good. That is absolutely true. Okay. Dr. Sayeed, why don't you take this one?
Okay. So I might have given this one away a little bit earlier in my introduction, but what does CKD stand for? The classic Chicago ketchup dog?
Right. What? Now, this joke was written by a doctor in Florida.
Yeah,
if you've been from Chicago, we know we never put ketchup on our dogs, right?
Constantly kind of dehydrated, Cubs, kidney, and deep dish, or chronic kidney disease.
All right.
Very
perfect.
good.
Very good.
So what is type 2 diabetes? So as it seems like a lot of you have familiarity in this room, type 2 diabetes occurs when the body doesn't effectively use insulin, leading to buildup of sugar in the bloodstream, which is different than type 1 diabetes, is when your pancreas, which is the hormone that produces insulin, just doesn't produce it. That's usually diagnosed at much younger ages, whereas type 2 diabetes is generally produced later in life because the body essentially is no longer producing to the insulin that is produced by the body. And therefore, as the slide explains, sugars start to build up, sugar levels get high, and those sugar levels, as they circulate through your heart, through your kidneys, through your nerves, they tend to affect everything. As I explained to my own patients, diabetes is a really insidious and savage disease. It doesn't spare any part of the body. As I'm sure there's some people in this room that probably have diabetes themselves know, it will affect and impact you in every way. And as I mentioned, it's the number one cause of chronic kidney disease worldwide. And that can be even in patients who have well-controlled diabetes. We're realizing now, through research that genetics will impact your, susceptibility to developing chronic kidney disease. But it's especially, higher risk in patients who do not do a good job of controlling their diabetes, whether that's because of diet, difficulty taking or struggles taking their medications consistently, and other challenges. So that's why it's really important that we, make sure we control the risk factors that can potentially lead to kidney disease.
Yeah. And that's a great segue into the next question here. So, Dr. Sayeed, what is chronic kidney disease?
Kidney disease is essentially when, for whatever reason, whether it's diabetes, as I mentioned, which is the number one cause, or high blood pressure, also known as hypertension, which is the number two cause in the world, when a patient is afflicted with these conditions, over time, the kidneys start to scar. So if you have lots of sugary blood that are, the kidneys are just one gigantic filter, essentially. And if you have a lot of sugar that's running through your filtration system, that sugar will start to embed in the kidneys. That will cause an inflammatory process. And over time, as the kidneys get more inflamed, the healthy tissue that's normally cleaning our blood starts to die off. And as that tissue dies off, the kidneys don't work as well. They don't clean the toxins. They don't regulate the things in our body that the kidneys are made to do. And as that happens, those toxins and things will build up in the bloodstream, causing patients to not feel well.
Perfect. I think you hit every point. Thank you. So, how are they connected, Dr. Sayeed?
So as I mentioned, diabetes is the number one cause of kidney disease worldwide. And as most of you probably know, the incidence or the number of patients worldwide that have had diabetes is constantly going up. Again, because of changes in food production and our diets over the last several years, access to healthcare, access to medications. Because of lack of a lot of those things, we see an increased incidence of diabetes, which therefore leads to an increased risk of kidney disease.
Yeah, and it sounds like this slide ties it together really nicely, right? So that the over time, that high blood sugar, like Dr. Sayeed mentioned, it's actually damaging those blood vessels. It's harming the filter, right? So the sugar is breaking the filter, makes it a hard time for the kidneys to do their job properly. Dr. Sayeed, why don't you take us through the different stages of kidney disease?
Okay, so as if it's okay for me to ask, by a show of hands, does anyone here in the audience have kidney disease that they see a kidney doctor for? Okay, yeah, so there's a few patients here. So, you might have heard your kidney doctor say you have stage 2 or stage 3 or, stage 4 kidney disease. Well, what does that mean exactly? We use the blood work that we draw during your visits or before your visits to determine essentially a percentage function of the kidneys, and then use that percentage to determine what stage you're in. So stage 1, which we're all stage 1 essentially. Anybody who doesn't have kidney disease is stage 1. That means your kidneys are essentially functioning normally. Stage 2 is when we start to see, the earlier stages of kidney disease, and that's when that percentage function, as I mentioned, is between 60 and 90%. As the kidneys get a little bit more damaged and get a little bit more scarred, we start to progress to stage 3. That is between 30 and 60%. Once you drop below the 30% range, then you're CKD stage 4, and that's from about 30 to 15%, and then anything less than 15% is what we call CKD stage 5, or if you are less than 15 and you are on dialysis, that's what we call end-stage kidney disease, or end-stage renal failure. That's when the kidneys essentially are no longer working, or working so minimally that we have to supplement the kidneys with dialysis. The thing that's kind of scary about kidney disease, it's good and bad, as I explained to my own patients, our kidneys are so efficient that it's really not until, for the majority of patients, that you get into this range here, CKD stage 4, and your function drops to about 20 or 25%, that most patients will start to develop symptoms from kidney disease. Up till that point, most patients will feel relatively well. So they say, okay, Dr. Sayeed, what are the symptoms of kidney disease? The earliest signs usually are fatigue. So when you get into that 4 range, as I mentioned, a lot of patients, when they hit 25 or 20%, will come and tell me, doc, I'm just so tired these days. I don't have the energy like I used to have. I can't get up and do the things I want to do. Then after that, it's usually appetite. Patients just don't feel quite as hungry as they used to. Sometimes that's associated with nausea and even vomiting. Sometimes patients feel, and they say, well, why is that happening? Because the toxins that the kidneys used to clean out of your blood, they're not getting cleaned out anymore. And as those toxins build up, which are just waste products from breaking down your food and the cells and other things in your body kind of breaking down, those toxins go up and you start to develop some of these symptoms. So that's why it's really important that, as we get older, we see our physicians, we have our annual physical exams so that they can draw blood, because you won't know it. So I have a handful of patients who came to me already at advanced 3 or 4, and they said, Doc, I never knew I had kidney disease. How did this happen? You won't know it because the kidneys, like I said, work so well that you need to see the blood work. That's the only way you can sometimes diagnose that a patient is developing kidney disease.
Yeah. But actually, a great summary, and I think, so what I'm getting from you is it's not just about the number, right? Especially as you progress to those later stages, right? You start to feel really bad, swelling, nausea, shortness of breath, the fatigue that you mentioned. So it seems like it's more than just a number.
Yeah, it's definitely more than a number. And that's what I always tell my patients as well, especially when they start to get into the 4-5 range and we need to start having discussions about kidney transplant and dialysis. Obviously, these are all very scary, life-altering things for patients. And so I always tell them, we have to look at the numbers, as Dr. Jain alluded to, but we also have to assess your symptoms, because as I mentioned, when you transition to dialysis, that's really, life-altering. And so we want to make sure we do that when it's necessary. So yes, we want to keep tabs on both things.
That's a good segue. So tell us a little bit about what blood tests you're looking for.
Okay, so there are a couple biological markers that we look at in the blood when we're assessing kidney function. And so those of you that since you have kidney disease, one thing your doctor might talk to you about is something called creatinine. Who here in the audience has heard that term, creatinine? Okay, good. So creatinine is just a waste product of muscle breakdown. And so when we do your blood work, it's only cleaned out by the kidneys. There's no other organ in the body like the liver or some of the other filtering systems that clean creatinine out of the bloodstream. It's only the kidneys. So that's why we use it to assess kidney function. So when that level starts to creep up, we know that it might suggest that a patient is starting to develop kidney disease. Now, there are instances in which the creatinine can actually go up and then come back down. It doesn't mean you have kidney disease. There are some instances where the kidneys can very briefly not work as well, but then go back to normal function. I just say that in case someone runs into that in the future. The next thing we often look at as kidney doctors is the one at the top there, BUN, and that is actually an acronym for blood, urea, nitrogen. And so urea and nitrogen, like creatinine, are waste products that the body will produce as it metabolizes your food, like I said, as our cells break down and turn over. And so that's another thing that we can look at when the BUN starts to rise. That might also suggest kidney disease. Now, normally BUN will go up, in concert with creatinine, but they're unlike creatinine, which is really only affected by kidney function. The BUN can be affected by some other things as well, which is why it's not really the first thing we look at, but it's definitely important.
Perfect. And maybe just help us focus on A1C. Tell us a little bit about A1C.
Okay. Really quickly, before I jump to A1C, Dr. Jain, the GFR here, the second, is that percentage function that we referenced when we were doing the different stages of kidney disease. And we use creatinine and some other parameters specific to each patient to determine the GFR, which is the glomerular filtration rate. The glomeruli are the little filtering systems in the kidney that do the cleaning. And so when that, we use that creatinine number and some other parameters to determine that percentage function. Okay, now to answer Dr. Jain's question, it seems like a lot of members in the audience today are familiar with diabetes. A1C is a blood test that we use to assess how your diabetes has been, well, we could use it to assess if you have diabetes, I should start there. And then also if you have diabetes, to assess how your diabetes has been controlled over the last 3 months. And so for those of you who have diabetes or have family members with diabetes, we want to keep that A1C as low as we can. Normally the goal is 6.5% or less. As you guys might have heard before, there are different also ranges of diabetes, right? So an A1C of 5.7 to 6.4 is what we call pre-diabetes. So you're not quite a diabetic yet, but you're getting into ranges now where we're worried about it. We need to keep a closer eye on it. Once you're at 6.5% or above, that means you're in full-blown diabetes. Now, once you get to 6.5, sometimes if you really improve your diet and your exercise and your lifestyle, you can bring that number back down below 6.5. But when you start talking about that specific number or worse, you want to be really, really vigilant and careful about all of those things. And sometimes, in consultation with your primary doctor, starting medication sometimes is also indicated to get that number down. So again, you avoid the long-term effects of diabetes.
So it sounds like you have a lot of blood tests to kind of help you make diagnoses, but just to help you follow your patients throughout their journey. So thank you for that. So Dr. Sayeed, what can you do right now?
So, there are a lot of things that patients can do. When I counsel my own patients, one thing I talk to them about is modifiable risk factors and unmodifiable risk factors. So what's the difference? So an unmodifiable risk factor is your genetics, right? You can't change that about you. Your parents gave you the genetic stew that you're made of, and you get what you get. Unfortunately, we can't change that. Your age, some of those other things, you can't change that. But when we talk about modifiable risk factors, that's things like, diabetes, high blood pressure, your diet, your exercise, things that you have a little bit under your control, in terms of how you prepare for those things, what medications you're taking, how compliant you are with those medications. And so those are the things that you want to do. So if you're a diabetic, the most important thing you want to do to prevent development of kidney disease, and if you have kidney disease, to prevent progression of kidney disease, is to control your sugar levels. So that means you need to monitor it, either with the old school AccuCheck, we call them, where you stick your finger and you check your sugar. And nowadays we have this wonderful technology called continuous glucose monitoring, CGM, which is, you might have seen on TV, like the Freestyle Libre, for instance, where you have a sensor in the back of your arm, and that is constantly tracking your sugars. Up to the second, you can see what your sugar is at. And that has been really profoundly impactful in terms of patients being able to always assess their sugar levels and see how your diet, how your medications are affecting them. And then both you as patients as well as your physicians can kind of monitor those trends and adjust things as needed to get those sugars in better control.
Perfect. And some call outs here to, maintaining blood pressure, maintaining that healthy weight. So it sounds like there's a lot you can do.
Yeah, there's a lot of things you can do, and it can be overwhelming at times, certainly, especially if you have a lot, more health issues. But at the end of the day, remember, we have to control these things to the best of our ability if we want you to do well. And again, in the specific instance of kidney disease, to prevent it. And also, if you have it already, to slow progression of it.
All right, so what happens when you eat a high carb meal?
Okay, so carbohydrates are essentially simple starches or simple sugars, things like, white bread, white rice, pastries, donuts, muffins, cookies, cakes. Those are generally made from, highly processed, highly refined carbohydrates that immediately get broken down to sugar. Those sugars, first of all, will circulate in your system, causing your blood sugar to go up, and then also eventually get converted to fats. So you want to do your best to try to avoid those types of carbohydrates. Does that mean all bread is bad and all rice is bad? No. If you eat those things, eat them in moderation. So don't eat them with every single meal if you can avoid that. And I know for my people, which are Indian people, it's hard for them to understand that. If there's any Filipinos in the crowd, all my Filipino patients tell me, I can't eat rice. Yeah, I'm not going to see you anymore. But you can eat brown rice instead of white rice, or wild rice instead of white rice, or multigrain bread, or wheat bread. those are complex carbohydrates. They're not refined and processed as much as the white breads and the white rices, so it takes your body longer to break those down. Your sugar levels don't spike, and it's much better in terms of controlling your diabetes and sustaining lower sugars over time. And then like soda, juice. One thing I have a lot of patients tell me is, oh, doc, I don't drink soda anymore. I just drink juice now. Juice is nature's soda. That's what I tell them. Juice is like Kool-Aid. There's no difference. All juice is you take the fruit, you take all the sugar out of the fruit, put it in some water and get, so you know, if you monitor your sugar levels after drinking a big cup of juice versus a cup of Pepsi or Coca-Cola, it's essentially the same. The effect is the same. If you do smoothies, that's a little better because you're actually getting the fiber from the fruit because it's all blended together. So if you like juice and you're a diabetic or pre-diabetic, you're better to try to avoid that. If you want to do a smoothie every once in a while instead, that's better.
Great. I think it's a nice segue. Like, how do calories different? How are they not well created?
So it's like, well, you know, then what do I do about my diet? Because either because of the things I like to eat or budgetary constraints, sometimes, you know, carbohydrates are easier to eat and obtain than like higher protein things. And I understand that, and I'm always mindful when working with my patients. But, you know, as the slide sort of alludes to, this is 300 calories of a salmon fillet, right, which is going to be mostly healthy fats and healthy protein, versus 300 calories from a donut. Although the calorie amount is the same, the way those things are going to impact your body are dramatically different, right? So it's trying to work with both your physician, if you're able to meet with a dietitian or nutritionist, and meal plan in a way that, yes, can you never eat a donut? No. I mean, we certainly want everyone to enjoy life, but you have to really do it in moderation, in small quantities, maybe just once a week versus eating a donut every day for dinner, for breakfast, or dinner. Instead of, you know, maybe some eggs with like a whole grain English muffin or something like that, which is going to be maybe the same amount of calories, but the impact on the body is much less than just eating something like a donut or, you know, a bagel.
Yeah, so let's think about that patient who may be eating a donut for dinner, right? So walk us through kind of what's going to happen inside that patient's body.
So as I mentioned, you know, simple carbohydrates are immediately broken down, and then your body is going to use those carbohydrates to essentially fuel itself, which obviously isn't a bad thing, but what happens when you do those things in excess, there's all this energy, all of these calories just sitting around that the body doesn't need anymore. What does it do with that? It converts it to fat. So if you do something like a complex carbohydrate or maybe some protein, your body will use that up quickly, and then when it doesn't have anything else, it'll start to turn to other parts of your body in order to produce energy so that you can function and do the things you need to do, like your fat stores, etc. So that's why, again, you want to try to, you know, lean more heavily into complex carbohydrates, high protein, those sorts of things versus just eating simple carbohydrates so that A, you can maintain good sugar levels, but also prevent, you know, weight gain and those sorts of things.
All right, so give us some tips, Dr. Sayeed, about managing diabetes.
Okay, so, you know, I've sort of alluded and addressed this throughout the talk so far, but the number one thing you want to do is, well, I won't say the number one. We won't number them, but we'll you know, prioritize them. And you want to maintain a good, healthy diet as best you can. Again, avoiding all the things that I've already talked about: sodas, candies, cookies, white bread, white rice, things that will be immediately broken down into simple sugars and then turned into fat, as I suggested. You want to stick to things like, you know, protein, complex carbs, what I mentioned just a bit ago. You want to make sure you take your medication. So that's the other really important thing, almost as important as maintaining a good diet, is taking your pills, whether that's metformin or Tradjenta or glipizide, or if you're on insulin, making sure you take your insulin, and then monitoring your sugar levels, right? If you take these medicines but you have no idea what the sugars are doing, then it's not as helpful. Yes, it's important to take your medicines, but what if with the medicines your sugars are still running high all the time? Then we need to make some adjustments. We, meaning the physicians in conjunction with you as the patients, need to make some adjustments. So monitoring your sugar levels is also very important. And then hydrating well, so drinking really well so you can kind of flush all of that additional sugar out of your system. You know, working in some protein, as it says. One really important point I want to make, is I know a lot of, you know, advertisements now say, eat oatmeal. Oatmeal is a great thing for breakfast, and it absolutely is. But make sure you eat actual oats, either steel cut oats or whole oats. instant oatmeal is just like eating a bowl of Rice Krispies for the most part in terms of how instant oatmeal is metabolized, because it's essentially blended oats. They like, blend them to make them sort of finer, more like powder, so your body doesn't have to work as hard to break them down. So try it if you can, and I realize instant oatmeal is a little more convenient sometimes, but if you have the capacity to either do regular whole oats or especially steel cut oats, try to stick to those versus just the Quaker Oats packet, and especially the Quaker Oats packets also have a lot of sugar in them. If you look at the ingredients, there's tons of sugar in those packets. So using steel cut oats or regular oats and then putting your own honey or a little bit of fruit or some nuts or other things is always healthier than just using like those instant oat packets.
Thanks. Anyone find any info on this slide surprising, or is this all kind of what you'd expect when you're a diabetic? Yeah, no major surprise. Although I did in my mind think, it's not a surprise, right? But I don't think I've thought about just how bad instant oatmeal is. So yeah, I think it's nice to highlight it.
And one point there, because I heard some people say they were surprised. One thing that also might have surprised people at the bottom there was eating something a little fattier at night actually may be better. And so, well, that's interesting. My doctors always told me to really make sure I avoid fat, which is true. You don't want to do anything in excess. You always want to do everything in moderation. But one thing that we have sort of as a society focused on a lot is fat, which again is important, but in lieu of focusing on sugar, which is actually in some ways even worse. So if you eat a bowl of Fruit Loops at night versus, let's say, like a whole grain bagel with some cream cheese, which obviously has a little bit of fat in it, those Fruit Loops, especially if you're diabetic, are going to be much worse for you than that bagel with cream cheese. So again, working with your doctors and dietitian nutritionists are important, but the main point here is avoiding simple and highly processed sugars.
Perfect. What are some other things to avoid to help keep that sugar level down?
So, our sugar levels are sensitive to a lot of things. We've spent a lot of time talking about diet, which is obviously one of the biggest drivers of sugars here. But actually, we're complex beings as humans, and there's many things that will affect sugar. So things like stress. If you're not sleeping well, there's a lot of good research coming out now that, if we don't sleep 8 hours a night, that can have all sorts of detrimental effects to our health. So making sure you get at least 7-8 hours of sleep every night. Pain, our sugar levels can be sensitive to pain. Obviously, we talked about donuts, not taking your meds. We talked about not hydrating well, even not seeing your dentist and some of the effects that can have. And then, some other things, not exercising enough, et cetera. So, we're always striving to just be generally as healthy as we can be, but these are some of the things that we can pay a special attention to.
Yeah, so I was going to say, you gave us a lot of stuff not to do. What should we do?
Okay, so what can we eat? Yeah, exactly, Dr. Jain, I mentioned a lot of things we shouldn't eat. Some things that we can eat are fresh fruits. So I mentioned earlier, fruit juice is not good. It's sugar water. If you like juice and you want to have a little bit a few times a week, that's okay, but you shouldn't be drinking it every day. So what can I do instead? Eat the whole fruit, because the fiber in the fruit actually helps balance the sugar. It helps your body process that sugar more slowly, and so that's much better than just drinking the juice. Non-starchy vegetables. Well, what's a starchy vegetable? A starchy vegetable are things like, white potatoes.
That's a good example.
Yeah, mostly potatoes. Even actually, sweet potatoes are better than white potatoes. So what are non-starchy vegetables? Cabbage, cauliflower, cucumbers, bell peppers, carrots. Those sorts of things are going to be much better. And honestly, for my patients, again, I don't mind them eating some fruits a day, but vegetables are always better than fruits. Whole grains, we spent a lot of time talking about that. I won't go into it anymore. Healthy fats like nuts, fish, even like, bread, whole grain bread with some healthy olive oil, that's okay. Egg whites or lean meats, and you can eat the yolk a little bit too. Again, nothing in excess, everything in moderation. And then, using herbs and spices instead of salt to help prevent, your blood pressure from going up.
All right. I think you already went through most of these here, but just like a nice look at some things to avoid. I think Dr. Sayeed already kind of hit on a lot of this.
This is more if you actually have kidney disease. These are things your kidney doctor and nephrologist should probably be reviewing with you from time to time. If you don't have kidney disease, these things are less concerning. The one thing I'll take away from this that I haven't focused a lot on is high sodium foods. And so when we talk about high sodium foods, when I bring that up with my patients, the first thing they'll always tell me is, "Oh, doc, I don't use table salt." Well, unless you're taking the whole cap off the jar and pouring the entire bottle of salt on your food, it's actually not that much. A couple of dabs of table salt isn't so bad. It's sodium or salt that is already in food. So like canned soups. Everyone thinks, oh, it's a can of soup. It can't be that unhealthy. If you look at the label, it has got a lot of sodium, sometimes like 200% of what you should be taking in a day. Canned vegetables, like TV dinners, prepackaged foods. So, fast food, those sorts of things have lots and lots of salt in them. So you want to be really mindful and try to avoid and limit. If you're going to drink a can of soup, they'll have now like low sodium soups. They usually have a green label. Try to buy those, and then you can put some hot sauce or some herbs like Mrs. Dash or something to get the flavor up a little bit.
I'm glad you kind of brought up that concept of canned foods. How many of you guys are like routinely looking at the labels of the groceries that you buy?
Good for you. Wow, most of you doing that. That's excellent. That's an excellent habit. Keep that up. For those that may not be doing it yet, if you can do that, it's really helpful. And it doesn't have to be to a T where you're keeping a notebook and writing it down, but just keeping a general sense of like how much sodium, and if you have kidney disease, potassium, phosphorus, those sorts of things that you're eating.
Great. So I think this brings the next question into a lot of context. So which of these foods that's sneaky sodium, right? Spinach, cottage cheese, bagel, or canned soup? Yeah. So.
Yep.
Oh, hold on. Cottage cheese.
Oh, it's a
sneaky sodium.
Well, so fooled all of us. It fooled all of us.
I thought it was going to be canned soup, guys. And I actually had access to these slides beforehand. Shame on me. But
so cottage cheese, remember, same thing. They make low sodium cottage cheese. So if you like to eat cottage cheese with fruit, that's fine. Just get the low sodium variety so you're not, starting your day off with a bunch of salt.
Yeah. Well, thank you. That definitely new to me. All right. So I'll jump in. So we gave you a lot of bad news, right? So I want to give a little bit of good news. And so we have a lot of treatments, a lot of hope that we can provide to our patients. So we've got already proven therapies. Does anyone know how a therapy gets proven? How do we prove a therapy works?
Yeah, I heard research.
Yes, sir. Yeah, very good. Research, double-blind studies, right? So it's patients who participate. And so keep that in mind as we kind of go through some of these proven treatments. So has everyone heard of Ozempic? Right? If you watch TV or read a newspaper, right? Probably you've heard of Ozempic. So Ozempic is in a family of GLP-1 receptor agonists. Those help. They do a lot of things in the body. A lot of really incredible things that we're finding out about: lower blood sugar, weight, and blood pressure. They can help reduce kidney inflammation and stress. We've learned that in clinical studies. We can help preserve kidney function in patients who are on these GLP-1 agonists. Slow kidney damage independent of the blood sugar. There's another class of medicines, SGLT2 inhibitors. These ones you may or may not have heard of quite as much. Farxiga is a kind of a classic example. Jardiance is a classic example. Thank you. So reduce protein in the urine. They can lower the pressure in the kidney filters. They can help shed the excess salt and water, and just overall support kidney and heart health.
And one quick thing, Dr. Jain, that I want to jump in on that I forgot to mention earlier in my talk is weight, right? Weight is a really important thing in terms of a modifiable risk factor, as I mentioned earlier. And that's where GLP-1s are really helpful. So not only do they have these effects, but just getting weight down alone is really important, because if you think about it, the heavier you are, the more weight you have, the harder your organs and your kidneys specifically have to work. They have to churn through a lot of blood in order to keep your blood clean. So if you can get your weight down with the help of things like GLP-1 receptors, that's an additional benefit to the actual kidney-specific benefits that the medication has. Yep, exactly. Yeah. Yep, it also helps with other things like arthritis, heart disease, heart failure. Sleep apnea. Yeah, it's very good.
Yeah. And then we've got investigational therapies, right? We're working on proving them. Why is it important that we look for new medications? Why can't we just rely on the old stuff? So improving the side effect profile, right? We always want to get better, right? I'm always looking for the best medicine with the most effectiveness for my patient and the least number of side effects, right? So I'm always on the hunt for new treatments, right, that can improve the efficacy and decrease the side effect profile. And so we're actually looking. So Dr. Sayeed and I have been working hard together to enroll patients for triple hormone treatment. So not just GLP-1, but a couple other hormones, GIP and glucagon. And we're seeing in trials, these have been more effective than just GLP-1. But this is not something I can yet prescribe as a doctor. This is an opportunity that we are bringing patients into clinical trials for. amylin analogs, right? So we know that GLP-1s have some limitations, right? They can cause some nausea, cause some stomach upset. We know that there's a little bit of drama around pancreatitis, inflammation of the pancreas, right? So it's really important that we find newer medicines that can help supplement what's already out there. And so Dr. Sayeed and I are working hard to enroll patients right now. We've got one study going on looking at a new type of drug, amylin analog. Amylin analogs help promote fullness, slower digestion, help improve blood sugar control, and support weight loss. And right now we're really focusing on folks with diabetes and offering them amylin analogs.
And these medications are going to be kind of the new wave of the Ozempics and Mounjaros and Wegovy's, right? So those are right now all over the media. Everyone's talking about them. The hope is that we get therapies that are even better than those, that help control diabetes even better, help patients lose more weight. And so these are the medications Dr. Jain and I are now working to investigate to hopefully bring to market. Eventually these medications will be commercially available to patients so it can help control their comorbidities, their medical problems.
That's a nice segue into talking about what studies do we have actively enrolling. So probably within a 5 to 8 minute driving distance from here, right? So we've got 2 research centers. One is at Andersonville on Foster and Ashland. That is a research center. We're doing a lot of great work there, weight loss and other treatments, but we also really focus at that site at memory studies. So we've got studies enrolling in Alzheimer's disease. We've got some psychiatric studies going on with major depressive disorder, social anxiety disorder. We're doing some vaccine work there. So we're looking at a vaccination against herpes to help prevent genital outbreaks, just as an example. At Ravenswood, right, the site attached to my clinic, so we've got some cholesterol research going on. We've got diabetes and obesity research. We love to educate our patients one-on-one about our studies. And so to help facilitate that, we offer free A1C screening for our diabetics. You're not signing up for a study, you're just getting to know us, get to learn about the studies, and we're able to screen your A1C at no cost. So what are some benefits of participating in the clinical trials that, right, we've got a couple sites just 8 minutes away? Well, that's how we're gonna help find new cures, new treatments for future generations. I have my private practice. A lot of my practice patients are very interested in enrolling in studies. Well, why is that? Well, they're interested in helping themselves. But a lot of my practice patients, they're amazing, right? They tell me, like, Dr. Jain, I want to help everyone with this disease, just as an example. You receive, go ahead.
Yeah, just as a quick segue, every medication that you are currently taking, if you're taking medications, went through a clinical trial.
Yeah.
Every medication had to be vetted and tested for its efficacy, if it's effective, for its safety. Every medication has gone through that. So, and those would not have come to market had it not been for patients who kind of like Dr. Jain alluded to, said, hey, I want to help move the industry forward. I want to help future patients.
Yeah, absolutely. Receive extra attention from doctors and actually a whole care team that are invested in your safety. So I'm going to tell just a little bit of a story here. So we were doing a study for cholesterol, and I have a wonderful cardiologist from Lincoln Park who had referred us a patient. And so we're doing a telephone checkup on this patient. And I have a very, very smart physician's assistant who was talking to this patient. And he said, Mr. Smith, you don't sound good. You sound really short of breath. What's going on? And the patient said, yeah, I'm feeling really, really short of breath. I haven't called my doctor yet about it. I haven't had a chance to call my doctor yet. So my physician assistant, right, bright guy, right then and there, tells the patient, I don't like the way you sound. I want you to go to the emergency room right now. Thank goodness, and so the patient did, right? Thank goodness the patient did, because he was right in the middle of a congestive heart failure flare, right? So again, it probably would have been identified at some point, but we identified it a little sooner because of that touch point, right? So you're really getting a care team that can help augment your care when you join a clinical trial.
Can I share another anecdote? Same thing. We had a patient who came in because they were interested in doing a clinical trial, and as part of that work, we did an EKG, just a general EKG to just check their heart to make sure it was okay. And we noticed they had changes that were concerning for a heart attack. So we went to the patient and said, hey, have you had a heart attack? Do you know about this? And the patient said no. So then we started asking, well, have you been having chest pain when you exercise, shortness of breath? He said, now that you mentioned it, I do. So we immediately said, look, we can't move forward today, but we want you to go to the hospital and get evaluated. That patient ended up having 3 vessels in their heart that were blocked and needed open heart surgery.
Yep.
And had they not come in for that trial, and we not caught that EKG, and these are, hand to God, these are true stories. We never would have caught that, and who knows, that patient may have had a heart attack down the line. So there are even benefits outside of the clinical trials, as Dr. Jain alluded to, with the safety and the opportunity to discuss some of your medical care with physicians like myself and Dr. Jain.
Yeah, so the more you look, the more you find, and in clinical trials, we look. And then lastly here, and it's not to pull your guys' chain, right? But really the opportunity to become a medical hero, right? It's getting the monitoring, getting the attention, but really helping move everyone's care forward. So when we think about clinical trials, like how does the public perceive clinical trials? So if you look, most of the public is not really that interested in clinical trials, right? So when we did surveys, let's say less than 50% of patients were actually interested. If you just ask someone on the street, hey, are you interested in a clinical trial? But what about people who actually joined the club, right? So what about those folks who've taken the plunge and participated in a clinical trial experience? How many of them would participate in another clinical trial? That number shoots up to 97%. Right, so that's a pretty high rate, right? Any organization would love to have a 97% return rate, right? Your restaurant would love to have a 97% return rate. And so I think it just goes to show you, right? Once you take the plunge, you learn about the study, you kind of see what's available, you meet your care team, and start to go through it. Our patients are often very, very happy. I see this all the time. Actually, before we're coming here, sorry we're a little late because I was actually just chatting with the patient. She's like, Doc, what trials do you have going on right now? And we were just kind of running through that. So anyway, it's once you join the club, overwhelmingly people stay in the club.
And a very quick side mention too. We understand that because of some of the history of these things, there's some stigmas towards clinical trials,
absolutely.
right? Things that were done improperly and were awful, terrible things. And Dr. Jain and I are very aware of those things. Like Tuskegee and some of these trials that should have never been done and are a dark stain on our country's history. But these days, all of these trials are very well regulated, right? They're regulated by the Food and Drug Administration. There are all sorts of we are constantly being monitored, constantly. None of those things that happened in the past could happen today, and you have my word on that. And more than that, Dr. Jain and I actually really care about our community that we live. We've both been in Chicago for several years. We care about our patients. We care about all of you here. And again, as just a human being, a person of God, and all those things, I would never, do anything that was done in the past. So if you have those stigmas or worries, we can certainly discuss those openly. We have no qualms about doing so.
Yeah, no, I'm glad you brought that up. And again, what I offer to my practice patients is the trials is just think about it as another care option. Not every option's right for every patient at every time, right? But again, it's been right for many of our patients. So I think with all that, we're going to let you guys ask some questions. So they vary. It depends a little bit on what is being studied and what research questions are being asked. We have some studies that are just like a one and done. It's just a visit with one single, we're just doing a lab draw and then you're done for good. We've got some studies, especially like vaccine studies, those might only be 3 months, 6 months, 12 months. At the other extreme, there are some questions that we need to answer over longer periods of time. So we call those outcomes trials. And so right now we've got a couple outcomes trials going on where we start a patient, like let's say on a cholesterol lowering medicine, and we're going to follow that patient out for up to 5 years. And that's how we're really learning. So it's a pretty big range of how long trials can last. You may wonder, well, how do I learn? Like, where do I find out about this information? We go through a patient's responsibilities, the schedule, how long things go during a really informative, regulated process called the informed consent. So when you come into our research center and one of our recruiters has already spoken to you, has a good sense, we think you might be interested in this study, we think you might be eligible for this study. One of our team members runs through a 10, 15, 20, 30-page consent form that gives out all the details about the study, the scheduling, the visits, the time commitment. So really great question.
So the first thing for diabetes, I'll start there, is that A1C test that I mentioned. So it's called a hemoglobin A1C. And that is essentially a blood test that looks at our red blood cells and how much sugar is on those red blood cells, to kind of explain it simply. And if there's a lot of sugar on those red blood cells, that means there's a lot of sugar circulating in your system. So that's the number one test we use these days. Is what we call the gold standard to test diabetes. And as Dr. Jain mentioned, we do that actually for free at Flourish. If you haven't seen your doctor in a while and are having a hard time finding one and say, well, I want to see if I have diabetes, we can bring you in and we'll do an A1C check for free to just make sure that you're not like at risk or have actual diagnosed diabetes. So that's the main test for diabetes. For kidney disease, there's the main test we look at is something called creatinine. And that is a biomarker that is cleared out, that is a waste product as our muscles break down and turn over, that is cleared out exclusively by the kidneys and no other organ. So that way we know that's specific to the kidneys. So if that number starts to go up, it tells us that there is something wrong with the kidneys. They may not be working as well to clear that out. And then the other thing we have is something called blood urea nitrogen, or BUN, which is another waste product of our bodies. And again, same thing. If that starts to go up, then it might be suggestive that there's something going on with their kidneys, that they may not be working as well. Yeah, albumin, that's a great question. Albumin is a marker of nutrition, but in certain instances, for the kidneys specifically, if your body is losing a lot of protein through the urine, let's say there's some damage happening to the kidneys, one of the main causes of that is diabetes, the kidney's capacity to prevent the loss of albumin flowing through the kidney into your urine is impacted, it's impaired. So if you're having a lot of protein in your urine and your albumin is dropping, that could potentially be a sign that you have a kidney issue.
I think it's a very smart comment. I look at albumin a lot in my patients, right? Both for nutritional status, but just to get a sense if they're leaking too much protein from their kidneys. It's actually very, very informative. I take care of patients with Dr. Sayeed with different types of like lupus, for example, as a kidney disease. So privacy is really, really important at every aspect of medical care. And again, just important, right? Clinical trials are just another care option within medical care. So we are governed by the exact same laws of HIPAA that your doctor is governed by in their clinical practice. So we cannot seek any medical records, as an example, without a patient releasing a medical records release, a consent to obtain those medical records. Our consent forms for medical records look just like your doctor's consent form. So that's like one method of protection. We can't just leave clinical data out, in an unsecure location, right? So we secure the clinical data, just like your doctors are securing the clinical data in their office. We have our own form of electronic medical records for clinical trials, and that's all password protected. To become a vendor, to allow patient data to be stored, they have to go through a lot of rigorous regulatory. They have to have security features that are built in on their end. So the way I would think about it is the privacy protections that we use in the doctor's office are largely copied and pasted to the privacy protections that we're required to use in a clinical trial. The answer is a resounding yes. It would be unethical to bribe patients to go into a study, right? Because that would be unethical, right? But right, we're asking you for a commitment of your time and what you're bringing to a study. So yes, we do compensate. It's a very regulated process. The compensation is already pre-agreed to. It goes through regulatory approval, and it's discussed oftentimes. Because patients understandably have questions, it's often our recruiters that are kind of having that initial discussion, but it's then rediscussed at the time of informed consent. So during that consent process, the stipend around the consent is an important point of discussion. But yes, the folks running that are sponsoring the clinical trials do compensate patients, right? Understandably, right? Because it is for your time. I want to really differentiate that. It's not a bribe, right? We're compensating patients fairly for their time. Let's say you're in a study and something happens, right? You go to the hospital. It may or may not be related to the study, right? People go to the hospital. But let's say you do need to get evaluated, right? Urgently, right? And it has some relation to the clinical trial. then yes, across the board, sponsors do compensate for that. You know, I had a vaccine study. This was years ago, peak time of COVID, and a patient, had a blood clot. The patient had calf pain, and it was really important at 11 p.m. that we didn't sit on that calf pain. We needed to make sure it wasn't a blood clot, and so that patient went into the emergency room to get evaluated. Thankfully, it wasn't a blood clot. It was just a pinched nerve in her back. But through the context of the clinical trial, that patient, the ER visit, the fees around that was covered. Any medical costs incurred around a clinical trial, that discussion is also part of your informed consent. And I personally have gone to bat for my patients with the manufacturer, with the research sponsor, to ensure that patients have had that covered.
With things like sucralose and all of these artificial sweeteners that have been on the market for a long time, the thing they use to sweeten Diet Coke or Diet Pepsi, theoretically, it doesn't cause the spikes in your blood sugar like plain old sugar will, but it also kind of tricks your body in ways that will make it think that there's sugar in the system. So it may not have the damaging effects that sugar does, but we don't really know, especially the long-term effects of these things. I tell my patients, I have patients who just love Coke, and they say, Doc, I just can't give up. At least every once in a while I need to have a Coke. So I'll recommend, if you don't mind the taste, do a Diet Coke every now and again, because ultimately that's still better than regular refined, cane sugar. Along those lines, there's a lot of new things out, like stevia leaf and monk fruit and all of these things. I mean, I'll be honest, they are all better than sugar. We have found that they don't spike the blood sugar as quickly, but I still think there's more research to be done. So to answer your question, if is it better than sugar? Yes. Should you still consume a lot of those things? I would say try to avoid it. At the end of the day, some of them are natural, but they're still processed and refined. So if you can avoid them, it's always better to just stick to things that are natural and, do things like fresh whole fruits or, smoothies, those sorts of things, rather than drinking or consuming those.
It depends. So it depends on what the type of studies are. It's typically, if the type of study is to look at treatment and the response to treatment, usually you cannot. Why I say it depends, I have some studies going on that it's not always a treatment, right? It's a blood test and we're following people over time. In that case, selectively, you may be able to participate in two studies at the same time. But again, typically no. Yeah. So the choice to be in a study is always yours. So here's another thing that I mention to my patients. When you sign an informed consent, you are not signing a contract in blood to stay in the clinical trial, right? We want you to stay in the clinical trial, but we have patients who withdraw consent from time to time, and we understand that. We've had, I'm trying to think of individual cases. So we had a busy mom who her daughter got very sick, and she was in a clinical trial. And she said, Doctor, I got to take care of my sick daughter, like chronically sick. Doctor, I can't do this anymore. I have to be there for my child. We didn't, we were very understanding of that. And the sponsor was understanding of that life happens. Some patients, when they go into a clinical trial, they go into the treatment group. Some patients go into the placebo group, right? They're not getting a true treatment. And some patients, when they aren't seeing the results that they want to withdraw from the study, right? And we always encourage our patients to be in a clinical trial, but the choice is yours, right? And so we understand, and the FDA understands, sponsors understand that for a variety of reasons, patients are going to want to leave a clinical trial. They are not. And so what's really, really important is that the services that you get through a clinical trial are not billed to your insurance. Now, I don't think it's necessary to inform your insurance about a clinical trial. Should you inform your primary care doctor and care team? You betcha. And on the informed consent is the number, how to reach the principal investigator. I am talking to doctors around the city all the time about their patients. If I have something that if I have a trial patient and there's something that doc needs to know, guess who's picking up the phone and calling him? Me and Dr. Sayeed, right? So there's a lot of interfacing, right? And where do a lot of our patients come from, right? So some of our patients come from these talks. A lot of them come from the docs, right? So because Dr. Sayeed and I are practicing doctors in the community, we are constantly discussing this available studies that we have with the docs in our communities.
Thanks for joining the MedEvidence podcast. To learn more, head over to MedEvidence.com or subscribe to our podcast on your favorite podcast platform.